Very good afternoon, everyone. I think we'll get on with our session on the latest in cataract and refractive surgery. I think we have an excellent lineup of speakers and covering a wide array of topics. And can we settle down?
I request everyone in the audience to please settle down. We are about to start the next session, which is latest in ophthalmology. Now, in the recent times, there have been many significant advances in the field of ophthalmology and especially in the field of cataract and refractive surgery. So, in this session, we would be discussing some of these recent advances and so related to advances in biometry, premium lenses, refractive surgery, and use of artificial intelligence in ophthalmology.
Can I request the Lalit?
Lalit.
So without further ado, we would start with the session. I would like to request the first speaker, Dr. Ajit Hazari, to start with his talk.
Can I have the screen, please? Yeah. Right.
He is talking about basically the use of swept source OCT based biometers, how to get the best from SSOCT biometers.
Thank you, everyone. Today we'll be going over the SSOCT biometers that are available to us to use in our practice.
Can you make it a little louder, Dr. Hazari, please?
Yeah. Louder. So if we look at the swept source OCT biometers available to us, we have 4 machines that are available to us. That's the IOLMaster 700, the Argos, Antirion, and the iStar. And I'll be speaking more on the Argos because I have a 18-month user experience. Common thing amongst all these biometers is that they all have a faster acquisition. They give multiple parameters. They have better penetration compared to the previous generation, and all of them are preloaded with advanced new generation formulae. Why are these advanced new generation formulae important? That's because if you look at the traditional previous generation formulae, they use the ultrasound axial length, and they tend to give hyperopic errors in long eyes and myopic errors in short eyes. The newer generation formulae, on the other hand, have algos in them, like the Barrett Universal 2, which we are all using, and the Hill RBF2, and they counter for these errors which occur at extremes of the axial length. But the downside of the newer generation formulae are that they require a large number of parameters, and this is where the new generation biometers come into play. So on an average, they require at least 5 or 6 parameters to calculate. So we've been using the Argos for more than 1.5 years now, and what it does is that within 1 second, it can give a single reading which covers the ACD, keratometry, corneal depth, corneal diameter, the CCT, axial length, which is sum of segments rather than the ultrasound, and the aqueous depth, pupil size, as well as the lens thickness. So throughout the measurement and the analysis, the Argos gives the user the control to evaluate the measurements as well as to change the quality and the measurements later on during the analyze mode. So this helps monitor the patient alignment and fixation for enhanced measurement accuracy at the time of acquisition. So here is an example which I did recently, just a couple of days back, with my junior most optometrist doing the biometry, and he got 5 standard readings within 42 seconds. And mind you, each of these readings consists of 3 additional readings. So that's a total of 15 readings in 42 seconds, which were within acceptable standard deviation. So next we go to the analyze mode of the biometer, and here we have the freedom to check the alignment of the eye from the OCT image, review the measurements, whether they are accurate, look at the quality indicators in detail for every measurement that we've taken. Then we also have the option of looking at the keratometry Myers of the patient to see if the ocular surface was good. And at the same time, it gives us the freedom to check all the boundaries of the A-scan waves according to the OCT image, and we can drag and drop them according to need. For example, if there's an ICL, the ACD would be less. So accordingly, we change the ACD from the map. The machine is also loaded with the Alcon Vision Planner, and this reduces the transcription errors, and it is very intuitive to use and helps in surgical planning at the machine. It is loaded with all the new generation as well as the older generation formulae. The full Barrett suite is available, but what we've been increasingly using over the last 1.5 months is the Barrett True Axial Length formula, which is tailor-made for this machine because it uses sum of segments axial length. So in the Vision Planner, I plan my incision location, I can calculate my SI, and I have my preferred formulae and IOLs which I use regularly. At the same time, by using different IOLs, I come to know what is the residual astigmatism, and I can plan my surgery accordingly. This is how the reports of the biometer come, and they are very intuitive and simple and easy to decipher. For example, on the left-hand side of your screen, you see the printout with all the demographic data, the actual measurements which have been ratified, verified, and the clinical picture which goes into the image-guided system in the OT. And at the bottom, you have the preferred IOLs and the actual IOL power that you're going to use. If you go into details of these measurements, you have all the detailed measurements and their quality parameters available to you on a single sheet. And on the third part of the report, you have the OCT scan and the correlating A-scan wave parameters along with it. So these swept source OCTs, and especially the Argus, has faster acquisition, gives multiple parameters, has better penetration, intuitive interface and easy to use, is combined with the Vision Planner and combined with the very own image guided system which we use regularly. If we look at the penetration of these OCTs, now all the swept source OCTs have much better penetration compared to the previous generation OCTs, but if you look at the Argos, it's at the top of the line. And if you look at all the reports that have come in the literature over the last 6 to 7 years, they all show that the Argus has the highest penetration in all kinds of cataracts. But where it really stands out is in mature cataracts, where you get a 90% plus rate of penetration. And my personal experiences, no financial interest, but my personal experience is that in the last 1.5 years, we've not had to use the A-scan at all in all our patients. So what this results in is a massive saving of time for us because we don't need to use the immersion scan or the A-scan. And what studies have also shown is that if you're looking at the overall efficiency of your workflow in the OT, then it can give rise to a gain of almost 60% of time saved for us. So in summary, if we are looking at advantages of these swept source OCT biometers, is that the fast acquisition, of course, we're able to get axial length in most cases. It has reliable and repeatable keratometry, multiple parameters tested, like you can use these parameters for your ICL planning also. All parameters are checked by the machine for quality and reliability, and at the same time, we too can do that. Then, of course, validation is important with other machines, and integration in the image-guided cataract surgery system. Thank you.
Very nice presentation, Dr. Ajit. I mean, my question would be, you did mention that the penetration with the Argos is better compared to the other currently available models, and it's a very important advantage. What are the other features unique to this, of the machines? This has been the latest addition to the armamentarium we have. How does it, are there any other factors in which it scores over the IOL Master or the Anterion?
I think what is very important is that you are getting a real-time OCT image on the screen when you are measuring. So if you can see at the same time whether the eye is aligned properly or not, whether there's a, for example, if it's a mature cataract, and in a mature cataract you're always wondering whether the fixation is going to be at the fovea or not, or whether at the visual axis or not. Now in the IOLMaster 700 you have the foveal focus. You don't have that here, but the machine captures the image and you can see the OCT. At the same time, you are able to see the alignment in real time. So if you see that in real time the alignment is not good, then you are sensitized to the fact that this measurement may not be accurate. The other thing is the keratometries I find are outstanding because the measurement is in a very small part of the cornea, the central visual part of the cornea. And we've seen it correlate extremely well with the IOLMaster 500, IOLMaster 700, and also the iTrace topo keratometries, which are in the central 3 millimeters. So I find extremely good correlation. And we validate our findings between the AutoK, the iTrace topo, as well as aberrometric case, and this machine. And we find excellent correlation, especially for torics.
What machine did you have earlier? The IOLMaster?
I had the IOLMaster 500.
500. And you preferred this to did you take a sort of a demo of the 700 versus the Argos?
I had access to 700 for a couple of years before I planned on this, but my main deciding factor besides this was that I was almost about to buy the 700 because of the non-availability of this, but the clinching factor I found was the compatibility with the image-guided system. Now, I've been using Verion for the last almost 5-6 years. And this is, it's a seamless progression because the same image, same data gets used for the Verion in the image-guided system in the OT.
You definitely found it an advantage over the IOLMaster. That's what I wanted to say.
Yes, it did, yeah.
Next we have Dr. Sheetal Bra talking to us about
Thank you.
my experience with textured haptic toric intraocular lens. Just to check up, the other speakers are Dr. Anurag Mishra, Dr. Anaga Herur, Sonu
She's in
Goyal.
another hall, and she told me she'll be back.
Yeah, I think they're in OPL, they should be here.
Thank you,
Yes,
sir. I would like to thank AIOC for this wonderful opportunity. So I will be presenting my experience with textured haptic toric IOL, which is the Hoya Vivinex toric IOL. So this is already known, the theoretical effects of IOL rotation on astigmatism correction. So if there is a 3% misalignment, it leads to 10% undercorrection of astigmatism. If it's 15% misalignment, it can lead to 50% undercorrection. 30% misalignment leads to no benefit of toric lens, basically it is of no use. And if it rotates by more than 30%, then it can even induce new astigmatism as a side effect, and it can even increase the original astigmatism, which will eventually lead to a significant change in the postoperative spherical power as well. So when we look at the various causes of toric IOL misalignment, you have primary causes and the secondary causes. So primarily, if there is a malposition of the lens, there is an error in the calculation of the target axis, if there is an error in the marking of the target axis, or the alignment itself is wrong, certainly you will have a postoperative cylinder residual. And secondarily, basically, if your lens rotates, you have implanted the lens in the right axis, but in the postoperative period there is a rotation. Most of the times it is due to a retained OVD and expansion of the bag, and this leads to rotation. And second reason could be also related to the shape and the material of the toric IOL haptics. So there have been some advances in this field. So what Hoya has basically done, they have given these textured rough haptic surface to the haptics, basically for a better grip in the capsular bag. So this is something which is a new advancement in the field of toric IOLs. So the design, basically, you can see there is this textured a bit of roughness which is provided on the surface of the entire haptic, and also the edge of the haptic is also textured, it is also roughened. So basically this modification, it results in a better adhesion, better positioning of the toric IOL in the bag, and it also prevents adhesions with the optic surface as well. So the lens comes in a preloaded multi-cert injector. So these textured haptics, they do not basically adhere with the optic, and thus when the lens is implanted in the eye, it leads to a very smooth unfolding of the lens as well. So these are some of the technical characteristics of the lens. Not going into much details, but the lens has an axis orientation marks given on the posterior surface, and this was a study done basically to look at the true rotational stability of a single piece hydrophobic intraocular lens, which was the Hoya Vivinex XY1 model. And in this, basically they checked the alignment of the lens at the end of the surgery, after 1 hour, after 1 week, 1 month, and 6 months post-surgery. And what they found was that the median rotation of the lens was only 1.1 degrees with a range of 0 to up to 5 degrees. And all the lenses in the study had less than 5 degrees of rotation from the initial axis following 6 months after surgery. So you can see that because of these textured haptics, the post-op rotation is extremely low. You can say it's negligible only because most of the times we do not want to re-rotate a lens which has rotated by just 5 degrees. So the maximum amount of rotation which was observed was just 5 degrees. So none of the lenses required any repositioning in the post-op period. And the Vivinex toric basically can correct an astigmatism of up to 6 diopters on the IOL plane, and it comes in a Vivinex iCert preloaded injector. So an additional feature of the Vivinex toric optic is also basically an active oxygen processing treatment. So this treatment is done on the optic surface. Again, basically this is done to reduce the PCO rate, and all these features are applicable to all the models of Hoya Vivinex, the geometric as well as the impress lens. So the geometric trifocal lens also has active oxygen processing treatment and the textured haptics, as well as the Hoya impress, which is the enhanced monofocal lens. So because of this active oxygen processing treatment, and along with the sharp edge design, there is also a very reduced, significantly reduced PCO rates have been observed. And this active processing also improves the wettability and adhesion of the hydrophobic acrylic IOL on the posterior surface of the capsular bag. So the lens also has a good tolerance to the post-operative coma if there is any kind of decentration or minor tilt. So up to 0.7 mm decentration is tolerable. So coming to my experience with Vivinex toric rotational stability, I have personally implanted 58 lenses, and in my post-operative data, what I found was that the mean rotation was 1.4 degrees. Of course, there were a few eyes which were high myopic also, but I've seen very good stability of these lenses in highly myopic eyes as well, and I'll be showing a case of high myopia treated with this lens as well. So the maximum amount of rotation that I saw was up to 6 degrees. Again, no lens required any realignment in the post-op period, and none of the patients had any astigmatic surprise. So this is a case of high myopia with pre-existing astigmatism, which I recently treated using the Hoya Vivinex toric IOL. And you can see the patient's pre-op biometry here. The axial length of the eye was 26.48 mm. The ACD was 3.87, and you can see that the lens power is plus 11.5 with plus 2 diopters of astigmatism. So after the phacoemulsification, this is the last piece, phacoemulsification. You can see that I'm doing the irrigation and aspiration. So I like to make a slightly smaller axis for toric lenses because I feel that it gives better stability. Now this is the use of the multi-cert injector. Again, it's a very wound-friendly and surgeon-friendly injector, and it goes through a 2.2 incision. You can also implant the lens under saline as well. And I like to use bimanual irrigation aspiration cannulas to rotate the lens. And I'm using a markerless system for alignment of the lens. And you can see that the stability of the lens is very good. I also like to polish the anterior, the surface of the anterior lens capsule. So just notice the position of the toric marks as I remove the IA cannulas. So you can see as I remove the IA cannulas, there is no shift. You can see that the lens is very stable in the capsular bag, and that's the end of the surgery. This is the postoperative outcome of the patient. Sorry, that was a video. So the patient did not have any post-op astigmatism, 0 cylinder, and the patient was 6/6 uncorrected vision. So to conclude, the Hoya Vivinex toric IOLs have excellent post-operative rotational stability in my own experience. This certainly leads to improved refractive predictability for corneal astigmatism correction at the time of cataract surgery. And this certainly also gives us a lot of confidence to counsel patients for toric IOLs with greater confidence, because you know that the lens has got very good stability. You're not going to see any post-op surprises. There's not going to be any significant rotation. So you can counsel the patients with greater confidence, and certainly this has made a huge difference in my toric IOL practice, because now, earlier I used to tell my patients, okay, you have a 10% chance or 5% chance of rotation, especially in highly myopic patients, because we know that sometimes they need re-rotation. But now, since I've started using this lens, even in high myop, every type of patients, I'm quite confident in suggesting this lens to them, and patients are also very happy. Thank you so much for your kind attention.
Thank you, Sheetal. What lens were you using earlier prior to the introduction of this lens?
I have been using all brands, basically Technis toric also, Biotech toric also.
And you find this is the most stable out of all the?
Yes, because I have not done any re-rotation for any eye.
And earlier you had to?
Yes, sometimes I had to realign.
So this you find is the most stable lens that you found in your practice?
Yes.
Actually, it's well established. In our own personal experience, most of these lenses are not to be rotated in the anti-clockwise direction. Occasionally, if it's slightly off and you want to rotate it, the other with the smoother haptics can easily be nudged to the opposite, in the opposite direction. But with these roughened haptics, you find that it's much more difficult to nudge them, and once you leave them, as she's shown with the overlay also, it stays right there.
Yeah.
And secondly, it's also been borne out with the other companies' experience. It's David Chang had published a significant paper where he showed that compared to the Alcon toric, the Technis toric rotated almost 5 times more often. Because of this, actually, the Technis toric also, they have introduced this roughened haptics now, and that has been available with the Hoya toric for a long right from inception. So I think this is the way forward that all lenses will move for rotational stability.
Certainly.
I think the texture, the texture and on the haptics have made such a lot of difference. It's not even in the Technis toric, even after it was, they roughened the haptics, it was not so stable as this lens. The next speaker is Dr. Ramamurthy, who's speaking on refractive surgery in hyperopia. Dr. Ramamurthy, please.
क्या यहाँ तो है Okay. Thank you. My topic is refractive surgery for hyperopia. As we all know, most of our population who have refractive errors are myopic. It's almost 1/3 of the total population. While at least in our Indian subcontinent, the prevalence of hyperopia is much less. Just about 3%, it's about 1/10 of the myopic population. And that's the reason I think as refractive surgeons, we come across this subset of population much less. But then they need to be taken care of, and there are some basics to be kept in mind. One is that good cycloplegic refraction, not just with
and avoiding wrong lens implant errors. So coming to the how to identify the cause, first the formal subjective refraction is very, very important. Thorough dilated examination to identify the surgical cause, like look for tight corneal sutures, placement, whether the placement of intraocular lens, whether in the sulcus or there is a subluxation of the IOL. Look for a distended capsular bag because of retained viscoelastic. Sometimes it may cause myopic shift. Look for presence of corneal pathology, mainly look for corneal edema or corneal scar that may even influence the refractive outcome. In the end, even in the retina, you should look for a postoperative cystoid macular edema that also can cause hyperopic shift. So, now you review the refractive history as well as the biometry, the IOL selection process and surgical record. Look for wrong patient biometry, transcription error, selecting a lens from sometimes from the ACOL column, or incorrect A constant, or also you should look for the incorrect formula in particular case. Check the axial length by repeating the biometry. Check for abnormal keratometry. Sometimes what happens, the presence of high case or astigmatism, sometimes you might have missed the underdiagnosed keratoconus. If there is no error, then you can contribute the refractive surprise attributed to the effective lens position, and you can expect the similar kind of error in the fellow eye also. So coming to the clinical management of refractive surprise, explain the error openly and offer an apology. But this is not a declaration of the guilt, but an acknowledgement that you are not achieved the desired target refraction. What I do in my practice, I take a second opinion that itself give a lot of confidence to the patient, even for us also. So what are the options? It's available whenever there is a refractive surprise. Doing nothing is also a good option, because most of this refractive surprise do not require a further surgery at all. Because if you left behind some amount of low myopia, always it gives a good monovision and patient can ability to read very well unaided. And most of the patient might have been there already using the glasses, they don't mind wearing the glasses later on. Always the benefits and risk of further intervention should be also very much explained. So coming to the management, correcting this surprise depending upon the first comfort of the surgeon, which intraocular lens used, and how long the lens has been implanted. Of course, those who are having a retained viscoelastic, of course, I do early capsulotomy that disperse the visco behind, then allow the anteriorly displaced intraocular lens to move posteriorly. Coming to the other option is corneal refractive surgery. But in my case, I normally wait till 3 months. For small amounts of residual liver, the results, I think there are two options are there. Either you can go with PRK or with the LASIK. For older patient, I prefer to do PRK because there is already they might be having some amount of dry eye problems with them. For younger patients, I prefer to do femtolasic. So coming to the what should be the ablation profile, most of cases we do with a wavefront guided treatment. So most of the studies down here shows that results with the wavefront guided treatments are much better than the topo guided treatment. So of course, LASIK will be always a safer option, because if you have done already YAG capsulotomy, because you cannot do the IOL exchange once already YAG capsulotomy might have done. And also you can do you can adjust the treatment if you can make the flap in LASIK. So what are the limitations for laser vision correction, especially if you left behind high refractive error, low corneal stromal thickness, and a limited availability of excimer laser in most of the surgeons? Of course, you have to spend extra cost. Now, other options are there, I think, IOL exchange or piggyback lenses. Especially IOL exchange is useful in effective in reducing the high degree of spherical error. The greatest advantage, it do not alter the anterior corneal surface and do not change the corneal refractive power also, and you don't require the special sitting like in the refractive surgery. So add-on or this one piggyback lenses, Dr. Ramurthy sir was showing in his one of his video about the piggyback lenses. Most of these lenses also works out very well, because as this corrects the manufactured refractive error, you need not have to know the original intraocular lens power, which is not required. And piggyback lenses are less accurate than the laser refractive surgery, but good for higher degree of refractive error. Avoid always risk of IOL exchange as well as those with the ocular surface wherever laser is not suitable. So add-on piggyback lens is the easiest surgery. The only disadvantage why I heard some of the patients, they may come up with the pigment dispenser syndrome. So I'll just conclude because of my time is up. So laser vision correction has been shown to be viable, non-invasive and accurate procedure to correct diametropy after cataract extraction with intraocular lens implantation. Lens-based procedure, IOL exchange or piggyback lens implantation are also possible alternatives. Piggyback IOLs technically easier and more accurate than IOL exchange. Better indicated in case with extreme emmetropia, corneal abnormalities, or when there is no available excimer laser platform required. I will not be showing my videos. Thank you again, the whole scientific committee, for this opportunity.
Thank you, sir, for a very informative talk. Any quick questions from sir? Anything from the audience?
I think, when would you resort to a IOL exchange?
So whenever a high degree of refractive error, especially those are like left behind around more than -4, normally I look for a IOL exchange. Again, depending upon what was the problem happened during the surgery, I need to look for exact how much is the pupil dilatation also. If pupil is not dilating that much, still my option will be last.
No, I quite agree with you, especially if you experience inappropriate power, immediate post-operative period, maybe an IOL exchange is a good idea.
Yes, sir.
But if the patient comes to you months later with a fused capsule, not only is a question of explanting the lens, but you do not know what is the exact power of the lens that should go in. Why exactly you face the problem. So putting in a piggyback lens where it's just based on the residual power is an easier option, especially if the amount of power variation is a little higher.
Yes, sir. I even tried with the piggyback lenses, sir. Results are very good. Only thing is that these lenses are a bit expensive.
Oh, you get the Indian versions now, which
Yeah.
are reasonably cost effective.
Cost
The
effective.
Sulcoflex lenses are quite expensive.
Very expensive,
And
especially
they
from
are-
Rainer.
You have to wait for them, especially if there's a toric component. But the Indian lenses are more reasonable.
Yeah, I tried in couple of cases. I was seeing your videos, but the gap between these two lenses, sometimes you may have some kind of layer in between. Sometimes it may disturb the vision.
Yeah, that was a problem which was experienced when, the early the piggyback lenses, both the lenses were put inside the back. And there used to be a interlenticular opacification that was called the red rock syndrome. Now that primary lens is in the capsular bag and the secondary lens goes in the sulcus, it's the overall diameter of 14 millimeters, this problem is not there.
Yes, thank you so much.
Thank you, sir. Is Dr. Sandeep Reddy around? Okay. So I would like to invite the next speaker, Dr. Shonraj Ganesh Rao, and he'll be talking on a very interesting topic on how to get smart with AI in ophthalmology.
Thank you. Thanks a lot. Can I get my slides, please? Okay. Thanks a lot for giving me an opportunity to talk here. This is my first time in AIOS and super excited. I'm relatively a new face here. I will take a little bit of time to introduce myself. I'm basically an optometrist. Then I went on to do a PhD in artificial intelligence at University of Melbourne. That's why this fake accent comes in. And after that, I came back to India to I joined at Remedio as a head of clinical research, and I involved in AI development tools. So there's a little bit of conflict of interest. I work for Remedio Innovation Solutions. Our company focuses on artificial intelligence-enabled multimodal ophthalmic medical devices. Right. Now, what is AI? Well, AI is a set of computer algorithm that is able to perform tasks which normally requires a human intelligence, right? Now, for example, what you see there is a black box there. Now, we train that black box AI with something. Let's say in this case, we input a car, and the AI will tell you whether that input, whatever the image is, a car or not. Similarly, you can train to do a fundus photo. You send in the fundus photo, and the AI will tell you whether the fundus photo has any pathology or not, right? Now, most of this AI, this black box AI to be particular, are data-hungry networks, meaning it learns from its own data. It's self-learned, and it makes mistakes, it corrects itself, and then it gets more accurate. Now, AI, when I talk about AI is such a broad field. There is, of course, what I spoke is a deep learning AI, which is a machine learning. There is also NLP, natural language processing, where the ChatGPT comes in. How many of you uses ChatGPT here? None? Nobody? Smart ophthalmologist there. Right. So if you want to be a smart, please start using the AI technology. So natural language processing works on ChatGPTs. And then, of course, we have computer visions. And then there are AIs which are involved for robotics. Now, what I'm going to talk today is I will be focusing on the upper part where the machine learning techniques. Right. Now, I'm going to skip a couple of slides in the interest of time. Now, how this AI can be used in our ophthalmology? Well, AI can be used to detect anterior segment pathologies, right? It can be used to detect cataract, corneal pathologies like keratoconus, any conjunctival pathologies, dry eye, tear film abnormalities. Similarly, it can be used to check your posterior segment pathologies like diabetes, cataract, glaucoma, AMD, ROP, and so forth, right? Now, when we talk about AI, many ophthalmologists think that AI is a screening tool. You just send in some images, it's going to give me some output. Well, yes, it does some classification. So what you see here in this part is, of course, it does some disease classification, but AI is not just that, especially in ophthalmology field. It can do segmentations. For example, you send in an image, retinal image, it can automatically give you the vasculature. You send in the cornea image, we can automatically segment your corneal nerves, right? We can also stage you what disease this particular disease condition is. For example, you send us the image of diabetes, we can tell you what stage it is. Similarly, we can even use it for much longer or much complicated algorithms like finding out disease progression or finding out structure-function relationships in glaucoma, right? Now, why we need AI? Now, when I told you, like, yes, this is all the use cases of AI, but today I'm going to talk about AI in ophthalmic screening, right? Now, AI in ophthalmic screening, why it is required? Now, if you look at it, in India, around 400 million people needs annual examination of eyes, but we have only 20,000 ophthalmologists, and most of you are here today, right? And you need to see at least 100 patients a day to complete these people, eye examinations, right? Now, most of the ophthalmologists today are trying to find out what is the problem, rather they must be spending the time on how I can give a specialized treatment and care, right? And most of the people nowadays are not aware about the chronic eye disease conditions, so they need to be identified and screened. So there is a care gap that is there, and which can be, bridged with using your AI. Now, how we can use this AI? So we can take a simple device, a non-mydriatic fundus camera like that, click photos of your fundus, run it on an offline AI algorithm which does not require any internet connections, and it is going to analyze the image and then say whether that image has glaucoma or not. As simple as like that, right? Now, we have evaluated some of the AI device technologies that we have developed. For example, this slide shows the AI developed for diabetic retinopathy, and we showed it has very good sensitivity and specificity in all different settings, in community eye screenings, in tertiary diabetic centers, in ophthalmic cares, in vision centers, and so forth. Similarly, we also gave these devices to primary healthcare workers in Kerala. These are nurses. We trained them how to click the photos and then run an AI. And using this, they were able to identify, the government of Kerala able to identify 2 districts which has higher prevalence of diabetes. So they can focus on those particular areas. So it has a public health perspective as well. We also have developed AIs for glaucoma, AMD, and ROP. The sensitivity and specificity of these is great. I'm going to talk one particular model there on here, where we gave these devices to the vision care specialist. So what they did was we gave this non-Medriatic camera to our vision care centers, that the technicians takes the images and then sends it to the AI, and the AI does a diagnosis of whether it is a glaucoma or not. Similarly, the images were transferred via cloud, and the teleophthalmologist sees these images and says whether they have glaucoma or not. Now remember, both of them saw only fundus images and made diagnosis whether they have glaucoma or not. Now most of you will agree, glaucoma diagnosis need not to be done only on looking at the fundus images. You need visual field information and OCT to make a proper diagnosis, right? So what we did was, this is probably the most important slide I want to talk. We called back set of participants to the hospitals, and the expert ophthalmologist here looked at all the participants and then made a diagnosis based not just on the fundus images, but also based on the visual fields and OCT. Now, if you look at it, the number of false positive referrals just by the teleophthalmologist and AI is better. So AI does a much better job. The number of false referrals reduces. Not just that, the number of false negatives also reduces with AI compared to the teleophthalmologist. So the most important question now, okay, you showed this, is AI is going to replace me? Is AI is going to replace ophthalmologists? Well, I say no. Why? Because right now what you do is, AI is just helps you to aid in the diagnosis, aid in the prognosis. Okay, I'm almost done there. Now, ultimately, the treatment care and the surgery plans all in your hands, and I do not think the AI will replace ophthalmologists, right? So with that, I finished this with this quote here. Now, if AI can be developed with humility, discipline, and scientific rigor, ethics, and with respect to the data and regulations, keeping the patient as the most important stakeholders, the AI has the potential to impact millions. Thanks a lot.
Thank you so much.
Yep.
Do you see any downside of using AI in ophthalmology? Anything which could be a limitation?
Well, I will tell you what. So AI should be right now used as a tool which can aid you at the diagnosis, and I think that's where it should stop. Not should replace it, an ophthalmologist per se. But the downside is like just how any test is. It still has the sensitivity and specificity of 90%, so you can't push it. So it's like any other diagnostic tool. That's how you should treat it, and I think you should start embrace this technology because it's right time people start using this AI in all different fields, and ophthalmology should start using this, and you should start using this as any other diagnostic tool.
I think for any AI platform to work, it's the machine learning and big data which is extremely important.
Yep.
Is the kind of information which is fed into it.
Yep.
And to ensure that the sanctity of the information which is fed into it is absolutely accurate, because it's going to
Absolutely.
predict subsequently.
Yep.
Is going to be a big challenge. You know, we ourselves vary so much on our diagnosis of diabetic retinopathy or angle measurement or disc cupping.
Absolutely.
So how to ensure that, you know, we say that this is predictive of glaucoma and this is not predictive of glaucoma, because 4 different ophthalmologists will differ in their diagnosis itself.
Right, right. So that particular slide, in fact, is done by 3 different teleophthalmologists, and then if 2 of them are in disagreement, the third one came and they made a final decision. But to answer more about how do we train this AI, now I skipped a particular slide on that. Now the training of AI is based upon what data you feed it, right? So curating and sending out the correct data is more important. And also it has to be done ethically. Like I have to censor all the patient related information. The AI should not learn about that, right? So the AI development part itself has to be make sure that the data curation for the AI has to be more ethically done and more accurately done for the AI to work. Yes, question. Right. All right, so the one I spoke about is a deep learning network. Now this deep learning network learns by itself, Okay, the more the data is better. Now, how much is the more is the question you are asking. That's, I can't put a number to it. So for example, the diabetic AI we used, we almost used like 1 million data to feed into it, right? So the more it is better it is. I'm talking now in the AI literature, there is something called overfitting of the AI model happens. So if you keep on feeding the data, they go on to overfit with this data, and then they start performing once when the new data comes in. But now, with the newer ways to deal with this AI, overfitting is not a problem now. Okay, we are seeing that even with the more data and more different ethnicity data, more different types of data, the AI is doing a much better job. Same with your chat GPT. It started, a few months ago, the chat GPT was not so accurate, and now it starts learning. Now, from the AI perspective, the AI scientists are not fearing now to overfit that data, right?
Thank you very much for enlightening us about the artificial intelligence. I hope just now, today, anyway, we are in trouble because when most of the patients of ours come with Google knowledge, and I hope they don't come with AI knowledge now to question us all the time, because as it is, all that knowledge is sometimes not very true, and all that's what they say is, all that Google gives us is not the truth. So it's my pleasure to have all the speakers with me today, and I think the two speakers have not come, Dr. Sonu Goel and Dr. Sandeep Reddy. Are they here? No. So I close the session today, and thank the audience for being with us. Thank you so much.